Hello and welcome to Move Well, Live Well, Perform Well. I am super excited to have a good old buddy here with me, Pete Williams.
Good
I've
to be
known
here.
Pete for 20 plus years,
Yeah, I think so. Yeah.
and Pete is a bit of a guru in the functional medicine space. He was the first guy to do the IFMCP, which is a famous, well known functional medicine course in the UK all those years ago. And he is a clinical educator, founder of Functional Medicine Associates in London. He has established various biomarkers over the years,
Yeah. Yeah.
and he has worked in this area looking at systems biology for a long period of time using advanced diagnostics and lifestyle interventions to really help individuals try to understand the root cause of chronic symptoms.
Yeah.
And he's highly regarded in this space and super smart. So I'm super excited to have a good chat and understand a bit more about functional medicine and
Pleasures.
where it's at currently today.
Well, that's Simon. That's a very nice introduction. Thank you for that.
No
Fire,
problems.
fire away. Let's see if I can answer some of your questions. Or
So I wanted to bust a few myths today and try and get a bit of an understanding for people on what is functional medicine and where is it today? How does it apply in the context of, you know, uh, Western medicine versus, these alternative philosophies? So could you start by just having a bit of an explanation about what is
what is it?
functional medicine?
Yeah, that's a really good question. So, I think if we're using sort of a medical term, the probably easiest way to think about it is systems thinking
Hmm.
medicine is the way that certainly a term that is termed in medicine. And I suppose that's taking in an individual and understanding that they're a big system.
Yep.
So the way I try to easily explain it, and probably the easiest way to do this is explain how I explain things to patients,
Okay.
is that they're coming to me because my skill set, my experience, and my training is a little bit like the conductor of an orchestra.
Yep.
So there is something in that patient's chronic disease or orchestra that's not working as well as we would like.
Okay.
My skill set is be able to look across the whole of that
Yep.
and find out potentially some of the underlying mechanisms that mean that they're not playing the music that you want to.
Yep.
And that could be simply like the woodwind section isn't working. So there might be part of the, I don't know, hormones that aren't working well. And generally, the skill set of an experienced practitioner is to be able to look at someone and be able to come up with a strategy that is trying to work on what's the most effective thing we need to work on now,
Yep.
medium term and long
Yeah.
term. So rather than I suppose there's a combination of rather than just blinkering down to one thing, and don't get me wrong, patients will come in potentially because they've got symptoms like pain, because
Yep.
obviously we swap patients with regards
Yeah.
to what would you do on this
Well,
one.
actually, it's interesting. The analogy that you've used, the song, the orchestra, is often how we would describe complex pain.
Yeah.
Like it's a very similar phenomenon in that there's a pain song that keeps playing, and
Yeah.
one errand part of that orchestra is continuing to play, which is interesting.
Yeah, so I think a lot of the time on that is that again, as you know, everything's easy until you have the patient in front of you,
Yeah.
because then what you've got to take on board is, and we discussed this just before, is that then you've got to, number one, you've got to decide, well, what content do we need to look at that
Yep.
would give us indications of where this patient is dysfunctional,
Uh-huh.
where maybe some of the underlying mechanisms that are driving ongoing disease are there, and you can measure and monitor that. And that can be even going back to using genomics. We do a
Yep.
lot of genomic work, and we tend to, my work in particular is usually, if I take a patient on, it's usually long term.
Okay. Yeah.
And that is because that is the amount of time frame that is going to take them from A to B.
Yeah.
But also, as I say, then you've got to apply that data into a program that makes sense. And a lot of time, as you know, Si, which is, it's very, I think everyone who's a clinician will share the same thoughts of that, is that you've got to try and work out between both of you what you understand this is going to take to get to that point, and then what your patient understands that they think it's going to take to that
Yeah.
point. And sometimes that's a big mismatch.
Yeah, completely.
So,
Patient expectation.
totally. And, I spend more and more, and unfortunately, I'm sure we're going to talk about this. I think there is no doubt that functional medicine is here to stay. I think there's a component of it which I suppose, like any new industry, it's quite an unregulated term.
Yeah.
And what does that mean? And I suppose what you mentioned on the IFMCP, I'm not a medical doctor.
Yeah.
But where I was, and I've come through, I'm an exercise scientist by profession, but I spent all of those years knowing that this was the right thing for me to do, but also knowing that for me to be taken seriously in my world, I needed to go through the most robust medical sort of strategy certification that I could, which is the IFMCP.
Yep.
Because I knew you wouldn't be taken seriously on that.
Yeah.
And I think there is a big mismatch at the moment with regards to how we regulate people in functional medicine. Because to be fair, anyone can say they're a functional medicine practitioner. And as you know, and I know, is that there are people who can just do a weekend course, and there's people like me who are, nearly 30 years into this now.
Yeah. And experience brings a lot of knowledge, and you see patterns.
Yeah. Yeah, there's absolutely no doubt about that.
Can I loop back? Like, medicine's siloed a lot of the time. You have your specialist, your liver specialist, your cardiologist, your musculoskeletal specialist, your neuro. A lot of the time, they're not communicating to each other.
Yeah.
Yet the systems that they all run off, the cellular level that they all function off, is all the same.
Yeah.
And is that where looking at functional medicine, a functional medicine approach, can piece and join some of the missing dots together?
I think that's a really good question. And I think that's really well explained. So how I would go back again, I keep talking about the conductor of the orchestra. Most of the time, most cases, I have a pretty robust idea of how we get people playing music again in the right way. The problem with that...
Can you teach me to play music?
Well...
Because my musical ability, I've tried to start learning how to DJ, and it's pretty pants.
Well, mate, I think we both did that a long time ago, and mine was probably even more pants than yours. But if I go back to what we were saying, is that, so when people come to me, I think what they get from me is someone who's probably got a better understanding than most about what needs to be done. However, there are going to be components that we do on a regular basis where we say, you need to go and see X and you need to go and to see Y.
Yep.
And so we do that all the time with trusted people. So obviously, when someone comes to me with a chronic pain syndrome, etc., that's some of the people I'll say, Si, we'll have a conversation, won't we? I'll say, here's Mrs. Jones. I'm just not sure, Si, will you have a look at it?
Yep.
And then obviously you'll feed back to me.
Yeah.
So I think I don't know whether multidisciplinary really works. In my experience, it doesn't. I think what I can do, as I say, I'm better than most.
Maybe that's because you haven't had what we do is almost multidisciplinary.
Well, we do, but it's such a big picture. And I think the problem is that any of these sections, cardiology, neurology, pain, they're so unbelievably huge.
Yeah.
That you spend your whole world in that and never be able to look outside. and I almost sort of see my role as a little bit like the GP of sort of systems thinking. It's like, okay, well, I'm pretty sure this is a problem. We need to do that, but you're going to need to go with that. So I'll give you an example.
So you're the specialist generalist almost.
I think that's a good way of looking at it. Yeah.
Yeah.
And I think also people generally want to be bought into one person being the main port of call rather than being dispatched out to everyone. So we're very careful about how we dispatch out. And we've only made relationships. So we've got good relationships, cardiologists, neurologists. We've got good relationships with hormone specialists in particular. But they are trusted people that I can, a little bit like me and you, where I can just go on a call and say, Si, I've got this patient, X, Y, and Z's going on. Will you have a look and just let me know?
Yep.
So that it doesn't detract from the work that you're trying to do. It's almost like coming back centrally, so that I can make those changes and then also sort of bridge the gap between the patients. And that's working really successfully for us. But yeah, that's sort of the way I believe that this systems thinking, full body, and people call it root cause medicine. And yes, again, it's what's the root cause of what's driving what. There are lots of these things that you can go in and look at, but that's really in our successes and defeats about, well, that's all well and good, but we've got to be able on Monday morning be able to give that patient instructions so that they know what they need to do on every single day. And I think this is the downside of some of these industries, like the longevity industry, and certainly a lot of functional medicine, is that there's a very strong misconception with regards to what your patient thinks they're getting on social media compared to coming to us. And a lot of those patients, we will have very robust conversations at the beginning with regards to, and again, no different from what you would do with regards to a patient coming in thinking you're going to do
what are the drivers,
little bit of shockwave on them and everything's sorted. I don't have to do the rehabilitation. And it's the same with us. So we're really honest about what might need to be done, how we're going to do it, what's the time frame, the investment in time and energy, and there's always a chance that it might not work as well as we would think. So they've got to buy into that.
Yeah, completely.
And I think I think
that's a big part of any health approach almost. Certainly that's what we do. I talk to the team a lot about, okay, well, you need buy-in. You need emotional buy-in. That client needs to be on board, understand the process, what's their commitment, what are they perceiving as their outcomes, do they marry up with what you can deliver? And only you can actually identify, well, not only, but you need to identify with them, okay, what are their goals and do they marry up?
Yeah. I think the other thing is that there are obviously stages of change.
Yeah.
And I mean, you'll know and I know that when a patient's ready, it's easy.
Yeah.
It's so much easier than people who are still in that contemplation phase. They know they've got to do something, but they're not quite ready to do that. And again, that's where, as we talked about before, in many ways, you've got to be that psychologist as well, and you've got to gently tease the conversation so that they don't feel like they're being told off. But also, I don't think there are certain things you can't fluff things. In my opinion, they need honesty, and maybe that honesty is not what they want to hear, but it's ultimately what's going to move the results for them.
Yeah, certainly, and I think that often is much easier with experience. And seeing these patients over a long period of time. Can I ask about? So we talk about systems thinking. So from a functional med point of view, there used to be this belief that functional med was probably more related to the gut. Okay. To a degree. Well, that was my perception a little bit. I know that's not the case, but what are the systems that you look at in terms of gut, hormone, immune system, mitochondria? How stress is impacting all of that?
So obviously what we do is we have a very detailed intake. We're trying to get background history. No different than any clinician would normally do. We probably have
yours is probably
it's a lot more robust. I think it's a lot more robust and a lot more detailed. So again, if I can use the analogies that I use at work and how do you work differently? What I say to individuals is that you have to think of me like a lawyer taking on a case. And so I have to do as robust as possible workup of your case history. Otherwise, the chances are I'm going to make poor clinical decisions going forward, and we're probably going to end up spending more of your money in an inappropriate way. Because, we have people who come in, they've done tens of thousands of pounds of testing. And they don't know what to do with it. And their practitioners don't know what to do with it. And so what I'm trying to say is, by the time I've done my due diligence before we come into that first consultation, I want to be clear to that patient that this feels like the way we're going to go. And these are the points that we will start with regards to the testing. As far as, is it inflammation? Is it, mitochondrial health, etc. You're taking in all of those and throwing them on the wall. But I suppose the question is, you're also looking at where have they had historically and recently symptoms? Because, regardless of doing the root cause, people, if they're in pain, they want to get out of pain. It's the most important thing. So it's a balance of deciding what we want to do and how we want to look at it. And all of those that you've discussed are in the mix. But I try to look at it and we try to work out well, what's the one that's way out? And maybe that's the first. So it's a little bit like, where's the low hanging fruit to get the most gain to start with,
Yep.
and to get the most value clinically? That's where we start.
And is that dependent on what is, the results that come back in, and what are some of the key worst findings, or the ones that from experience are just easier to change, easier to click, and will make a more profound difference on that individual?
Again, comes down to, as an experienced clinician, you're trying to feel what is likely going to be my best decision based on the context of what that patient brings to us.
Yeah.
So the decisions are made on that.
Yeah.
And because there's no point me coming in hard and heavy with stuff that's going to move earth, is really going to move the earth, if they're not ready to do it and they're not in the space to do it. So again, it's very difficult to say how I would go forward, because you've got this flexible framework that you've got to work with, and you're making the best decision, and you're saying to the patient at this time, this is what we think we should do now. But obviously we're also we're building the foundations now. We're doing maybe some acute care now, i.e. we'll try and get you out of pain. And it might be that, you might need to take some medication first. But we're already trying to think about your journey and the strategy for the acute, the midterm, and the long term as well. And again, it's important that, again, is that you do the lawyer looking at the case, so that, it's just so many tests that you could do, Simon, based on symptoms. And it really, in my opinion, again, and also just from experience, is that I think with functional medicine, there is this point where there are lots and lots of labs out there doing amazing new testing that sound all cool and all great, but it's a question, is that going to allow me to move this patient on in the next steps?
Yep.
And so I'm very cautious these days with regards to, how we spend your money, because you are going to have to spend some money. There's no doubt about that.
Yep.
But
because they're not cheap, a lot of
no,
these
they're
tests.
not. And
some go off to the States, don't they? Still,
a lot of them. There's some amazing labs out there. UK labs, in American labs, and it's a pain in the ass to say. I mean, even some of that's actually going through the testing procedures, it's a real pain.
Yep.
So again, it's a question of, sometimes it's just really painful for the patient to actually do, some of the urine metabolites and blood spots. It's just a real pain. So it's really important that we say, almost like present the menu. I really need these now. We can't get away with not looking at these. And maybe we can play those out, see how we go over a period of time, and then knowing quite well we've got the others that we might want to look at. But you're always playing with a picture that changes as well.
Yeah.
So as I said, I will only ever test on stuff that I think is absolutely necessary. Now, again, that doesn't mean to say that sometimes you've got a patient who is fixated on a test particularly, and maybe you test them even though you probably think it's not maybe as scientifically validated as you would want, but you're playing with that psychology, because you've got to be able to bring them forward and give a little bit of give and take.
You've got to engage the patient.
Yeah. Which of course is the art of, I suppose, being a practitioner, if you like.
So of the workup that you do, there's, lots of questionnaires and information that you'll glean. There's a subjective interview that you'll have, and you'll either be presented with some tests because lots of people are doing aspects of this, or you'll send off for some testing. What gives you the most information? Is it your clinical gut sort of intuition, or is it the lab results, or is it just that combination of everything and the pattern? Because I talk to my team a lot about pattern recognition from a pain point of view and a movement point of view, and I think clinicians get very good at recognizing patterns. Is that what you're picking up?
Yeah. I think you've got a reasonable idea from their emails. You've got a reasonable idea for as soon as they come in the room, and your conversations with them, how this journey might pan out from that perspective. It's very difficult to say what tests I would use. But as I said to you, I think the key thing in this is that inherently you're clinical intuition tells you that this is going to be a pain in the ass through no
Yeah.
one's fault for the patient, because as I say, a lot of patients come in with incredibly complex backgrounds, conditions, etc. But you just inherently know that this is going to be a winner, or this one's going to be a pain, and I need to be very careful about how I transition through this one. And again, I want to say that through, it's no fault of the patients at all, but some patients, have had a very, very difficult life.
Yeah.
And you'll see this with pain, because this is
Yeah,
sort of some of the multi-complex models that we see with pain.
Yeah.
And the question is, as I said to you, is that, is there a way that we can measure this pain objectively?
Yeah.
Or is this more how that patient's brain is viewing the outside world that's generating the pain?
I mean, pain is all a construct of the computer's interpretation of all the stimulus and inputs and what's going on internally. So I think it's always their pain for me. That's what I think. So it's understanding, okay, well, can we just dial that down from a sensitivity point of view alone without changing anything else? But
or whether you can develop a program that in their mind is going to help them reduce their pain.
Yeah.
Because a lot of the time, I think when me and you, they're just not fit enough, they're just not strong enough, they don't move enough.
Yeah.
And it's a question of, well, maybe there's a way that we can manipulate that conversation to say this is the greatest, this is the greatest thing, and all this is going to help. And you dress it up in a way that sort of goes with their construct of how they see their pain.
Yeah.
So I think it's very difficult to try and explain that to people, because you can't really explain it. You just know in your head, I'm going to have to play it in this way, because this is probably how this is going to work. And I've never sort of, as you get, as I say, a little bit sort of older in this, is that you recognize that, just as I say, because you've been in the trenches for such a long time with patients,
you don't look that old, mate.
Well, I'm 56, so it's
you're doing pretty well for 56.
I'm doing okay. Yeah, well, I don't know. There's a few bits of me that's probably maybe not doing so well, but I think the point is just every day is a learning process. So you build your library of. I sort of feel as though I should play it this way.
Yeah. So, in terms of getting the test results out and the interventions, I mean, I've been in our world for 20 plus years. And the more and more I come back to it, the simple 6 pillars of lifestyle and wellness are just the key. Stress, sleep, nutrition, exercise, social, those relationships, and then the negative habits. Are your interventions not just, are they tackling those factors? And is that the patient's sort of last 10, 15 years of not managing those sections very, very well, as along with, other illnesses and medical stuff and genetics that contribute to things?
So I suppose your question is, where is all the gold dust?
Yeah.
And the gold dust is in what you've just said.
Yeah.
And I think
that's a much easier way of saying it.
Some people are disappointed when they come in to see me because they think I'm going to give them all this fancy stuff, when I can just say, well, here's the gold dust of what is going to make the most impact to change some of these disease markers that we've got.
Because exercise for me is almost one of the biggest levers that you can pull.
Well, I would go on to say I think it is the biggest lever.
Yeah.
I think it far outweighs nutrition. There's plenty of evidence to show and studies on that.
Yeah.
And people just don't do enough.
Yeah. Completely.
And it's like, I don't know how much more to dress it up. It's like, I've been very clear here, is that, so I had a woman came to see me in a mid-60s cardiovascular patient, which is predominantly what I do these days. And I think she was slightly surprised that I would say, here's where the magic dust is for you going forward. They say, you're not fit, you don't have enough muscle mass.
Yeah.
And that's your journey over the next couple of years. And that will make by far the biggest intervention for you.
Yep.
No test or anything is going to touch that.
Yeah.
And I think, again, is this misconception that there's this new world that gives you fancy new tests. And they are, don't get me wrong, testing used well. We've had some life-changing patients all the time. We get that all the time. So it's not that they aren't amazing. It's not that they don't bring up. But I think there is nothing that hits the mark the most or changing thing the most than doing the fundamental basics well.
Yeah.
So as you know, if you don't sleep well, you're going to be in pain.
Yeah.
So if you don't
yeah.
exercise enough, particularly as you get over your 40s, you're
Yeah.
probably going to be in pain.
Yeah.
And so I think, as I said to you, it really depends on sometimes the narrative that that patient is coming in with. And sometimes we've got to debunk that narrative because it's not going to fit what this patient is going to get from us.
Fix.
Well, they do, and there isn't any.
No, there's no magic. Okay, we talk about these longevity drugs and, you know, there's peptides out there at the moment.
But can I come in on that?
Yeah.
But it's just there's no decent science to back any of that. I think the longevity movement, I think is based on nothing at the moment. You know, I mean, who's going to take rapamycin on the street? I mean, come on. I mean, it's just like
there's good animal studies, but
I just think
what does that replicate in humans?
you know, I think this is where I think we probably lost our way with quite a lot of things. I'm not suggesting that, you know, it's a little bit like, because we get a lot of people who come in for longevity, but it comes back to, well, should we see if you're doing the fundamental basics correct first? Because I don't see anything that beats that. And sure, listen, if you want to spend 2 or 3 or 4 and 500 quid a month on supplementation, I don't have a drama with that. So if that's your choice, and we could argue that, you know, I mean, let me think about resveratrol, which was thought to be going to be the longevity agent.
That's from
David
red
Sinclair
wine as well.
But you would have had to drink something like 23 bottles of red wine to get the amount that you need. And of course, what we've gone on to find is that it just doesn't have any influence on longevity. Now, do these things influence the metabolic pathways that maybe are associated with chronic disease and maybe, you know, inflammation? That means that, you know, if they're accelerated, you might not live as long. Sure.
Yeah.
But there's no real data to suggest any of this is going to make you live longer.
Yeah. So,
except, of course, getting fit and strong.
GLP-1 agonists. So, are they? Okay, we're coming into medical territory a little bit now. You know, I think, you know, the peptides, the longevity drugs, all of those, you know, the senescence and sort of drugs that you can look at from a longevity point of view are maybe the 5% sprinkling on the top of doing all the basic stuff right. But GLP-1 agonists are having quite a profound impact on people's metabolic health, cardiac health, mental health a lot of the time.
Yeah.
We were just touching on it before.
Well, we do. I mean, and
I've
got a lot of experience with this. So I just want to be clear. As I say, I'm not a medical doctor, so I can't prescribe any of these. But I've probably got 10 patients at the moment who have been on GLP-1s for 2 or 3 years. And it's a small sample size, but every single one of them, I would go, wow, this looks like a wonder drug, as long as we're controlling for X, Y, and Z.
Yeah.
So I just think about one of the guys I saw, again, who was genetically he's at risk of type 2 diabetes. He's always had slightly elevated lipids, centrally deposited obesity, high VAT scores, so the visceral adipose tissue scores, some indication of fatty liver, liver enzymes are elevated, have been for the last few years. And even before that side, because obviously we build very personalized programs, we get a lot of data. The argument, I mean, he's been with me nearly 30 years. And really after 10 years, we knew that his weight was the determining factor with all his biomarkers.
Yep.
So if his weight was going up, his biomarkers was going the wrong way.
Yep.
And look, I want to give this understanding of other people that we've seen, because I've got quite a lot of female patients and male who have lifelong had incredibly low body image because they've been overweight.
Yep.
And then suddenly we bring a medication in, and then over time, it's completely got rid of that. It's completely got rid of food noise. Most of them just don't, again, side effects that we know is that they just don't really want to have a drink when they were big drinkers.
Yeah.
And so on every single level, and of course, with one medication, we're getting rid of the blood pressure meds. They don't need to be on their lipids anymore. And so time and time again, it's just been an absolute no-brainer. It's almost like too good a drug. It's amazing. So, but I want to be clear.
Long term, we're not yet sure, because there's not a lot of longitudinal data, but it looks incredibly safe.
Let me give you the other sides that we see, because obviously you like every medication, there's pros and cons. That we definitely see signs where cramping It's usually a bigger sign. And we're trying to obviously adjust for electrolytes, we'll adjust for magnesium, etc. So that's one of the side effects we
Muscle
see.
mass
Yeah,
is a big issue.
so that's an interesting one on that. Is that I don't really. It's almost because the GLP-1s are so good, people just eat a lot less, and then generally what happens is that you don't eat enough to find metabolism, but also keep the muscle mass. So that is definitely something that we see and account for as well. So this is why if we've got someone on a GLP-1, probably 2 to 3 times a year, they will have a DEXA muscle scan for us, and we're working through that. And also they'll have the blood work to make sure that
you're also educating them, and they're in your program. They're all already doing strength training.
They have to be. There's non-negotiables. Because if you go on a GLP-1 and you're not strength training, for me it's a double whammy. So we're trying to offset everything, and again we can get into the ins and outs of what are you doing on the strength training aspect. But again on that, these people just aren't hungry. But so yes, you need some sort of know what you're doing, sort of know what to look, but the cost risk analysis of that medication against everything else, and against from longevity and cardiovascular disease, type 2 diabetic risk. I know it's only an N of probably about 10. It's been unbelievable.
I mean, but that's what we're seeing with our patient group as well. I think that's the perception out there. That's the, anecdotal evidence that everyone's reporting, or the various sort of case studies that is making, it's the best drug to almost have come out in the last 20, 30 years.
And look, as you know, I'm in the world where
you're not allowed.
I'm not allowed. But number two, I think people will also see me as a figure in this industry from a point of view of, God, listen to him touting drugs, and it's not touting drugs at all. And I think this is part of one of the problems we see with, I think, you're either everything has to be natural or the other side. And I think a lot of the noise on social media, I think a lot of the way things are going are, if you're never going to take a decision that may be the best decision for your patient has to be pharmacology, then I think you're not doing integrated medicine as far as I can see that. Because we see this all the time. So I want to finish on GLP-1s. I think what I've been amazed with GLP-1 is a very simple thing, and that is I believe that humans should be, we should be moving around all the time. We should have enough muscle mass. And, in a sense, we were always starving, so we didn't carry a lot. And I think what you see with the GLP-1s over time is how it undoes, how that lack of body fat, both internal, so intramuscular, in the liver, wherever else, is that you see how once you strip that away and strip that away and strip, how all physiology comes back to normal.
Well, you're resetting their metabolic sort of base level, aren't you? Have you had many that have come off that, or are they sort of micro dosing on it?
Yeah, so it's a really good point. So the question is trying to understand what happens and give them a better understanding of what happens when you come off. So several of ours we've got, and again, time of the year. So everyone at the moment is, let's not do it over Christmas because this is where you're going to double, triple whammy problems. So again, timing of the year matters for us. And I always say to our patients, spring and summer is the best time to think about coming down because life is just a bit happier when the sun is shining. So there's a time frame on that. But also what we're starting to do is decide what is the optimal weight we want to get to. And then how do we want to come down? How do you want to come down? And we usually ask those patients to titrate over time. And then we can adjust as we go. So I think the risk is just doing it on a whim and then not realizing the consequences.
There needs to be a strategy.
There's a structure to what we want to go to. And as long as they're aware of that, it's like, listen, in 4 months, we'll do your DEXA muscles again and see how we go. And we'll put that into the context of why that result is. But you are going to put weight on again. But that weight is no different from, I say to people, being on a very heavy exercise regime and normal dietary calorie restriction. You can only hold that for a period of time before things start to come back. So it's just a question of, but I do think it's allowing us to reset them for sure. And significantly reduce their risk.
Which is amazing. Within the framework of functional medicine, I always had this vision that, okay, Pete, I'm struggling with this patient who appears to have systemic inflammation. We can't identify it. Okay, this is your cup of tea. Or, a long COVID sufferer, or someone who's got some autoimmune stuff going on, or maybe rheumatoid arthritis,
Yeah.
or
Yeah.
chronic fatigue, gut stuff. Are there specific illnesses or specific areas that it feels like you can really target?
Well, that's a really good question, Si. I think once you understand the functional medicine model, and once you've had a lot of experience with it, it's almost like your operating system of how you can go into any area.
Yep.
So I don't think it really matters what is the condition.
Yep.
Because you've always got the model.
Yeah.
So I mean, obviously, it does matter from a point of view. If you've got no understanding of sort of some of the drivers of autoimmunity, it's never going to be as good as having a deeper understanding.
Yeah.
But I think once you're comfortable with the model, you can always help someone. Because the way you think is the most important thing.
Yep.
The way you're understanding how, if you like, the etiology of autoimmunity links into the symptoms and where you may need to go to start thinking about, well, what's been done before? Was that successful? Wasn't it? And what are we missing with this?
Yep.
So that's where, you do come in, particularly long COVID, which, we've had some amazing successes, but we still, I think about Jimmy, the 25-year-old kid that I'm still looking after 5 years now. And, he's done amazing. Don't get me wrong. His life is so different from where he was 5 years ago because he just couldn't really function.
Okay.
So we've done a brilliant job.
Yep.
But he's not the same guy as he was before it.
Yeah.
And we see a lot of that.
Yeah.
And that's incredibly frustrating.
That post-viral space, not just with long COVID. I mean, we see quite a lot of that, merging with chronic fatigue, ME.
Yeah.
Is really tricky.
Yeah.
I think we've got a bit more understanding with all the evidence that's sort of come out of long COVID, which is one benefit of COVID, because there's probably been a bit more of a light that's shone on some of those symptoms and how they can group together. But I think we're still scratching around in the dark a little bit.
Yeah, it's again, and I suppose, how do we start with those? We come in and, once they've done the due diligence on the background information, we can start looking at, well, what are your symptoms? And, you can start saying, okay, well, based on the symptoms and based what we know on the literature is that here's where we'd start. There's no doubt that the gut microbiome and
mitochondrial health.
Again, but then the question is, well, why mitochondrial health being so debilitated by by COVID, and there are lots of theories out there about, and again, is that you can't keep up.
Yeah.
So in every stage, you've got to sort of look. Here's the best that I can do at this time, and it's not easy. We probably are going to have to do quite a bit of testing because, it's even like we're still debating whether there's still a reservoir of COVID sat there in the gut, just continuing to be pushed out.
Yep.
And whilst you can't really test for it, we can test for is the microbiome in good shape? Is there a gut wall that is compromised? And that means we're going to have leaking not just of the COVID virus, but anything and everything that stimulates the immune response. And then the question is that are we dealing with a patient who presents with long COVID, CFS, MS and ME like presentation? Is that a consequence of ongoing exposure, or is that a consequence of how they've been left from long COVID? And I don't think we can still answer those questions because it's a question of, well, we're pretty clear that Epstein-Barr is elevated in a lot of patients or reactivated in a lot of patients. And so the question is...
And for everyone, Epstein-Barr is a virus.
Yeah, it's a virus. We all get it as kids, generally, almost all of the population, and your immune system takes care of it. Yeah. So the consequence and the argument is with long COVID, is your immune system still fighting against COVID because it's still there with a reservoir pushing it out, and just exhausting your immune system? Or are we looking at you've been left with an immune system that's exhausted because it's had to fight COVID all this time, and then that's allowed dormant viruses to
To
spark
wake
up.
Yep.
So, we've had lots of cases, Si, where we've just, I don't know what to say. And the problem with that is that unless they're spending thousands and thousands of pounds to say, we probably need to test for Epstein-Barr and cytomegalovirus and see whether there are, you end up just running out of money. And that's where the frustration is.
Yeah, yeah.
And that's where, again, it's very important that you let them understand what this might look at the beginning, because one rabbit hole leads to another rabbit hole. And then you sort of, well, I'm not sure, and we might need to test for this. So long COVID has been one of those where I sit here thinking I know quite a bit about it, and yet I know nothing about it.
Yeah. I mean, I think that's experts in their field. The more they dive in, generally will sit there and go, you know what? We still have a lot to know. We still have a lot to learn, despite them being the gurus in that space.
Well, I think you just got to be honest, haven't you? As I said to you, there is. I suppose what happens as you get older, you have more understanding of all the layers that go with it.
Yeah.
And there's probably more layers that are contributing.
Yeah.
And so you're not as naive, so that you don't come out with stupid statements, because you're just like, I'm not sure.
Yeah.
It could be X, Y, and Z, but here's how I think we should play this over time.
Yep. Functional medicine was sort of seen as very alternative, like a different approach, and it's become more mainstream. And I think Western medicine also doesn't have all the answers.
Yeah.
Are we getting to a situation where people are just combining those a little bit more, those approaches, and it can almost blend?
Good question. I think it really depends on, I think with COVID, I think the general public's trust in conventional medicine, in my opinion, has been shot. And we could argue why and how.
There's probably lots of factors within that.
Well, again, and government policy,
responses, and
But I also think is that, I was definitely a critic from a point of view of, why wouldn't you take? I mean, there was a couple of studies that came out of Spanish studies that they were emergency intensive care studies that looked at giving patients who were coming into the intensive care big boluses of vitamin D, and it reduced intensive care usage by 75%. Now, again, for me, for such strong studies like that, why the hell wouldn't you do it? It's cheap as chips to do it. It's not a problem. But I think...
And 90% of people, well, I don't know what figure, but a huge percentage of the population have low vitamin D.
Yeah, so it's a no-brainer for me. However, that is on the assumption that you're expecting people in certain places and maybe in conventional medicine as well to think that way. And they just don't.
Yeah.
So I look at this, but I think what has happened is that society has been left with, they don't trust conventional medicine like they did before.
Mm-hmm.
So that, I think that's where we've been left.
Is that also that there's a world of knowledge out there? People were Googling, now you've got ChatGPT, and people are able to throw symptoms out there and come with a degree of understanding. And I think a lot of that can be useful because we want to educate patients, but actually a lot of the time the context is completely missing in that sort of information. And that leads to problems.
So this is where we come to our classic line, which is content is king. So you can come in with your ChatGPT programs and you're telling me what needs to be done.
Yeah.
But that is never going to work because the context of how we would play that out based on your life and where we are, it's just not going to work.
Yeah.
So I'm a massive fan of AI, massive fan, but I think it has to be utilized in a way that is effective. And again, I think people don't fully have an understanding of how functional medicine works. I think there's a big gap at the moment from a point of view of, you do this all naturally, or you're in with big pharma, and that's absolutely not what I've seen from coming up 30 years of evidence-based practice. So I think where I'm currently going at the moment, I think there's a lot of different disinformation that is, I think, really bad on the natural side.
Yep.
And I think the point is there's so much data out there, Si. I think there's a couple of things. Unless your job is a reader of research.
Yeah.
And I mean, look, we've got several degrees.
Yeah. Yeah.
We understand to some degree how to read a scientific paper, but whether or not we're sat there reading the statistical analysis and how it works and, the biases and how they've set it up.
Frankly, you don't have time.
Well, we don't have time, but we don't understand.
Yeah.
So I think you have to go with what the totality of the evidence suggests.
But there is a little problem in that, a small little problem. I'm going to play devil's advocate here, in that a lot of the time when you're working at the front line, you're seeing things and maybe using tools that don't have that full hard level of evidence, those RCTs, because it takes time to get that.
Agreed. What I would say on that is that this comes back to, you've got evidence-based medicine, and then for what we do day in, day out, it's evidence-based practice.
Yeah.
And so that's where you're
evidence-based led.
Well, you're taking. I like to look at it as I said to you, is that each person you're making a decision based on maybe what the guidelines have said.
Yeah.
And sometimes those guidelines like this just doesn't make sense for this patient.
Yeah.
So I've got to lead my intuition with this, the point of view of I don't think that's what we should do.
Yeah. Yeah.
But that's sort of the individual basis. But I think there's a lot of misinformation out there, and I think social media drives it, and I think it's really unfortunate. Yeah. And look, I'm not going to sit here suggesting that I know everything at all, but particularly in my world, cardiovascular, I see a lot of unfortunate cases that come in where they're not listening to cardiologists.
Yeah.
Because they think that the cardiologists who are cardiologists, I'm not a cardiologist. I spend all my time in cardiometabolic for sure, but I'm not a trained cardiologist.
Yeah.
So, I'm going to be humble enough to say, yeah, I really know what I'm doing, but these guys spend all their time in this area.
Yeah.
So if they're going to have a really good idea what's going on, it's probably those guys.
Yeah.
And so you get patients coming in. I had one guy came in, he went to see two separate cardiologists, and they both told him exactly the same thing, is that if you really didn't do some quite intensive measures based on your test data, your chances of having a heart attack pretty soon are huge.
Yeah.
And he felt that he could come to me because I was functional medicine, that I was going to
change all of that.
I was going to give a completely different scenario to him. And I said, I just totally agree with what your cardiologist is saying. And, this is, I think, just because I'm well known in functional medicine, that doesn't mean to say that I ignore everything in conventional medicine, because again, the guidelines are the guidelines for the reason. I suppose the argument with that is that, I think everything is getting pulled out of context. It's giving the wrong message, and you can make a narrative however you want, Simon.
Completely.
And you can find the science to fit it.
And patients do that.
Of course.
Yeah.
So this was a guy who refused to do something about his cholesterol level, even though he had very, very advanced cardiovascular disease on imaging as well.
Yeah. Yeah.
And so, you're like, again, this is where it comes back to, is that you've got to be honest with your patient's story and how they're viewing the outside world. And, I think he was a bit shocked that, I wasn't going to be able to pull all of that calcification out. And I'm just like, you've got to understand where you are.
Yeah.
Within the context of your disease.
Yeah.
And this is not a time that any supplementation is going to work wonders on the stages that you're in.
So we were speaking off air before, in that you have really moved into that cardiometabolic sort of space. What are you seeing in that space? Are you seeing that mix of conventional medicine, take your statins, let's get your exercise levels right to optimize your cardiovascular system and metabolic health? Or what approach are you taking?
Yeah, so we've sort of developed our area in this quite extensively over the last 4 years. So basically, when people come to us for cardiometabolic health or cardiovascular health, they come to see me as the conductor of the orchestra with this.
Yep.
But I've also got professor of cardiology and a consultant cardiologist as well, because when we get the patient in and we do our due diligence at the beginning, we have to work out where their risk sits.
Yep.
And if their risk is high, we need a conversation to say, we probably need either to go to more robust testing for you, and that might be invasive imaging like a CT angiogram with contrast, because we are really not going to ultimately know your risk until we get the best imaging that we can get.
Yeah.
And from there, ultimately, we can build the best personalized program you want, and or that may include some kind of pharmacologically led process.
Yeah.
So we're not saying either or, but what we're able to do is say, here's where we think the risk is. And what I would say on that is that, again, we go with the guidelines, and I think the guidelines are completely manipulated in a lot of stories, because the guidelines, all the best guidelines in the world, European Society of Cardiology, American Heart Association, American College of Cardiology, all say the same thing. And that is, if you can have a good enough lifestyle enough to bring most of your all your cardiometabolic markers down to where we want them, you're good to go.
Yeah, yeah.
But if you can't, then you need to make a decision about, well, how do we do that?
Yeah.
And then I think, and so this comes into the story about, is cholesterol good or cholesterol bad? And again, I think that's been a completely manipulated story in the press, which I believe is, we see this all the time, which I think is a dangerous story, and doesn't fit the totality of the evidence of what it says. And I think the stories are manipulated to create a narrative. So, because the guidelines are saying exactly that. It said you need to do the best job you can. And if you can't get there, then you probably need a little bit more help. And that's how we, and that doesn't have to be a statin.
Yeah.
There are lots of other lipid lowering medications, but we see many patients who, it's not about cholesterol. It's about your type 2 diabetes. It's about your triglyceride levels. It's about your making sure that your endothelium is perfect, making sure your blood pressure is down. And they're all in the mix for sure.
Yeah. Yeah.
But again, what causes everything? You can't have atherosclerotic cardiovascular disease unless you have all of those LDLs and ApoB containing particles crashing your artery over time.
Yeah.
You just can't.
Yeah.
So it's a fake message that is out there.
So you've got to weigh the risk up, and then you involve the experts in that particular field to give guidance.
Yeah. So this is how we do it. As I said to you, I've had a lot of experience in this field, and honestly, we build amazing personalized protocols.
Yeah.
Personalized, really, the genomics are there. We're doing some really great stuff. But there still comes a point is, even with that, it's guesswork until we have the imaging.
Yeah.
Because I can't tell you what your risk is. So I had a conversation with a guy this morning who, one of the GLP-1 people, and all of their cardiometabolic markers over the last 18 months are normal now.
Okay.
And they weren't before. So what I said to him, I said, look, now your atherogenic particles that we're measuring are back to normal levels.
Yeah.
They haven't been there for 3 or 4 years. But I need to be clear to you, that doesn't negate your risk of cardiovascular disease, because we don't know how much has gone on in your last 60 years.
Yeah, yeah.
And atherosclerotic cardiovascular disease is a disease that starts in utero and develops all the way through your life. So we don't know.
In utero?
Yeah.
That early?
Yeah. So we know that's part of it.
Yeah.
And, there are many unfortunate studies where they've taken catheters of car accidents, teenagers, and we know from those that we're already seeing advanced lesions in teenagers. So all the guidelines have changed, and all the guidelines are going fundamentally the lower for longer on that side.
Yeah.
And this comes back to evidence-based practice as well, because all of the stories that I used to believe that cholesterol's not a bad molecule. But the story I tell them, and again, it's because people say it's all about endothelial function. It's all about, blood pressure is a big player for sure. But the question I say to you is that, you've got to sort the endothelial dysfunction out, and then the particles won't crash the artery. The numbers in an optimal patient for LDL, the number of particles are so astronomical, you can barely write it on the page.
Yeah.
So once you start getting an indication that it is 6 and 27 zeros of particles that are crashing around, you start to get an understanding that it doesn't matter how healthy you are and all the other stuff.
If that's there,
yeah.
Then
And
you're in
we
strife.
see a very, when you're talking about subsets and patterns, we tend to see, it's really strange, but we have these optimal individuals who are coming us from just optimizing the health. They may be early 50s, they've been super fit, super lean, super physically active, really good VO2 maxes, super insulin resistant, no inflammation, and yet they got very advanced cardiovascular disease because they've had elevated lipids throughout their life.
Yeah, yeah.
And so, again, when you start seeing that all the time, you start thinking, all this other stuff doesn't make sense.
Yeah.
And then, and again, so almost like it's not that I've gone full circle, because I don't not believe all those are not important. And there's lots of evidence coming up with what we call the vulnerable plaque.
Yeah.
So again, so there's lots of stuff that we don't know, and there's lots of stuff in cardiology that we don't know. But what we're trying to do is, with the totality of the evidence that we've got and the risk that we've got and the imaging that we've got, we can give you what we think is the best,
the ideal,
the best scenario in this case.
Yeah. Okay, cool. Where do you see functional medicine sort of moving? I know, you've mentioned that, okay, it's got a bit of a bad rap maybe at the time because it's less regulated compared to some other specialisms. Where do you see it? You sound like you're shifting back towards just an integrated approach.
Yeah. So where's it shifting back? It's a really good question. I think that, so if I give you, with our team, so as you say, if I talk about our cardiology, we've got two cardiologists, consultant cardiology and a professor of cardiology. And what's really lovely about that relationship is that you'd think there'd be a hierarchy, but I fundamentally sit at the top of it. And I think that is because, particularly with Rasha, who's the prof, is that she gets it. And so she knows what I'm doing.
Yeah.
And that's stuff that she can't do.
Yeah.
So there's an incredible respect to someone who gets it and fits all of their models as well, and fits everything with regards to how do we build lifestyle from a cardiology perspective. So I think more and more what will happen is that you'll have probably people like me who can go into maybe complex sort of departments and say, well, why haven't you done X, Y, and Z on this? And bring that sort of orchestral sort of conductor looking at it and say, yeah, but you don't even do an X, Y, and Z on this one.
So the specialist generalist.
Yeah, I think you need it. Yeah, I think that's probably a good way of looking at it.
Very, very good physician. That's where physicians have sort of been lost a little bit, I think, in contemporary medicine or Western medicine, because they were the bedrock of looking after people and understanding the multi-systems incredibly well.
Yeah, but this comes back to, so yes, I think you're right, but this ultimately comes down to when people are coming in, they're complex. They have complex conditions and they have complex lives. If you have no capacity to understand that, you're never going to get anywhere.
Yeah.
So you've got to build a relationship, and that relationship has got to be the story behind the story, and you've got to be able to play that out over time.
Yeah.
And they've got to buy into you from a point of view of, we're a team effort. We've all got responsibilities in this, but they've got to be confident that, you're going to help them move it forward, and they've got to trust you.
Yeah.
So I think that's because it comes back to, I know, because your missus is GP.
Yeah.
And I still, beggars belief for me, how GPs can get it right almost all of the time with such short time frames.
Oh, on the NHS, yeah.
And it's unbelievable. I couldn't do it.
Yeah.
So you just look at that and go, wow, massive respect
Yeah.
for that, because it's just nigh impossible to take the whole context of why someone's coming in with a condition and
In that
actually
very small chunk of time.
and be able to have a good shot at giving them some benefit from that consultation. I think it's unbelievable. So from that, it's just like, wow, a massive kudos on that side. Because I have the time.
Yeah.
We've built our programs
which is fortunate.
You have to pay for the time because it's the time on the understanding. And, it's a time like, why didn't you tell us that 3 months ago?
Yeah.
Because there's always something that's missing. Oh, I forgot to tell you this. So for me, chronic disease and the success of it is you need to have enough time to be able to play this out, to constantly be in conversation and constantly have the touch points to touch in all the time. And I think this is where, I suppose, in many ways, the health coachy sort of arena is getting bigger, because you need touch points on simplicity.
Completely. So you're going to hate this question, but what are, I think exercise is key. What are some of the basics that people should be doing? Okay, sleep, exercise. Are there any supplements that are your go-to, like vitamin D? You know, everyone should be supplementing right now.
Yeah, so it's a really good question, and I think again you can look at that, and I think based on my experience and how you read all the data, I still run off. So I disagree with what the NHS says, but you've got to remember that the NHS, when they do nice guidelines, they're for mass population, and also there's a cost implication because we'd be bankrupt if we tried to do it.
Well,
So
we are almost anyway, aren't
well we are, but so I get it,
Yeah.
and it's a little bit like when you're doing risk algorithms.
Yeah.
They're built on big populations. And there is always the cost that goes again, because again, when we're doing the cardiology, we'll use some risk algorithms, but they're not really giving the full context of the story. So what are our go-tos? So generally, what we tend to do, I say this all the time, is that we run vitamin D genomics, and the reason why we do that is because it's unbelievable how many people have incredibly poor vitamin D genetics.
Okay.
And what that means is that they can have a whole summer of sun.
Yep.
And by the time we're testing them, it's not that they've not absorbed it. There are, number one, you've got to absorb it, and then you make a sort of a non-active vitamin D. Then it needs to be transported to the liver. It gets changed through a few pathways where it goes from inactive to active, and then it's got to get on what we call a vitamin D bus. So a vitamin D binding protein. It's got to get on that bus, and then it's got to be taken to every cell of the body, and then it's got to be accepted by the VDR receptor, which again is like the bouncer on the door. And for a lot of people, all of those stages don't work so well.
Yeah.
So with those, we have to push the label with vitamin D. So again, the guy I saw this morning, we've got 20 years of historical data to show that if we don't supplement him in the winter, he gets into trouble.
Yeah.
And of course, the key thing is that, like on this, Simon, is that I've said for a long time is that this, for me, this doesn't make sense that this isn't public health strategy.
Yeah.
Because it's value for such a low-hanging fruit, which is buttons.
Yeah. It's a simple.
So we tend
solution.
with patients twice a year, we'll do their vitamin D levels, and we'll adjust the dosage accordingly.
Yep.
And
do you do it after summer, and then
So we tend to do late autumn. So now we're doing all ours, because what we're doing is setting them up for the worst time of the year.
Yep.
And I like to still, and again, we can argue about what the numbers are, but the COVID papers and vitamin D, because COVID is still around. All right, it might be changing its form, but I always utilize that as the guide. As well, if we're talking about catching a virus, then most likely going to be this. And they show us that the data shows that 125 nanomoles is the minimum requirement based off those studies. And
which is so much higher than the normal range.
Yeah, and again, you could argue, well, what are you basing that off, Pete? And that is my basing that off what the data is telling me. But all of our patients do better when the sweet spot for me, probably 125 to 175. I get a little bit antsy when we get people going a bit higher, and we've had people come in at actually enormous levels of like 350, but never seems to cause any problems. But again, I get a little bit sort of scary once we're getting over 200, and it's like, you need to cut this down. And we see a lot of people who are overdosing on on vitamin D. Never seen anything where it's been clinically relevant yet. But general people will come in, just shoving it down and not even realizing what they're taking. So there's stuff that you don't want to. You could have caution to. We've never seen on test anyone who hasn't needed any more magnesium. I just think that's part of modern life. So yes, on that one, we see a lot of people with methylation defects that tend to increase the risk of, well, a whole host of spectrums with regards to, and chronic disease with regards to methylation. So, but again, that comes back to, I think you can go a long way with a multivitamin mineral.
Yep.
And I know that goes against some of the evidence that you support, but again, it comes back to, we see this in evidence-based practice because we're doing the testing.
Yeah.
So we're not guessing on this. We're guessing on the fact that we probably give you a multivit and see what. However, that doesn't mean to say that if you take a multivit, you're going to magically assimilate and absorb all of that. That is some of the other things that we've learned, is that you can throw a lot of supplementation at people. And again, it's the same thing with food. You can be on the best diet in the world, but if your digestion and your gut microbiome aren't in an optimal space, the chances of you getting the best out of them, is reduced.
Yeah.
And you know, we've seen lots of patients in the past, very big supplementation regimes, and they've really not worked in a way that we would be happy with.
Yeah.
And I think that explains that.
Pete, we could chat all night, but we've got to wrap that up there. Thank you very much.
Pleasure, mate. Thank you for having me in.
To have your insights. And yeah, we'll have to chat again.
Great. Thank you, Si.
Excellent. Thank you, mate.